Dr. Nirukshi, can you hear me?
Yes, I can hear you.
Great. Thank you everyone for joining this month's GP Café on spinning patients, clinical pearls and pitfalls, which will be a practical guide to diagnosing and managing vertigo. Before I commence with the introduction of our speaker, I'd like to remind everybody to ensure their mics are on mute. And if you have any questions for the speaker, you can ask it at the end of the webinar or even type it in the chat box. It's my pleasure to introduce our speaker for today's session, Dr. Nirukshi Fernando. Dr. Nirukshi earned her MBBS from the University of Science and Technology in Chittagong, Bangladesh in 2008. She currently serves as a medical officer in the ENT department at Sri Jayawardhanapura General Hospital, bringing over a decade of specialized experience in ENT care. In addition to her clinical expertise, Dr. Fernando has been an active member of the SJGH Clinical Society Council for several years and currently holds the position of Assistant Secretary. She's also a general practitioner with nearly 15 years of experience and a proud trainee of the 11th batch of the MCGP program. Her commitment to professional development is evident through her associate membership with the College of General Practitioners of Sri Lanka and her active involvement in several key committees, including the Women's and Children's Affairs Subcommittee, the Medical Education and Continuing Professional Development Committee, and the Social Activities and Public Relations Committee. We're honored to have Dr. Fernando with us today to share her insights and expertise. So please join me in welcoming her to this webinar. Over to you, Dr. Nirukshi.
Good evening. Am I audible to you?
Yes, Dr. Nirukshi, audible.
Okay. Thank you very much, Dr. Rashmira, for your kind introduction. Before I begin, I would like to sincerely thank the Spice Route Movement of Sri Lanka and GP Café for giving me this valuable opportunity. As a MCGP trainee of the College of General Practitioners of Sri Lanka, it is truly an honor to be here and share this presentation with you all today. So today my topic is spinning patients, clinical pearls and pitfalls. A practical guide to diagnosing and managing vertigo. Hope you all can see my screen also.
Yes, Dr. Nirukshi, can see.
Okay. What is vertigo? Why it is important? Like every day in our GP practices, there might be 1 to 2 cases at least of vertigo. Normally in setup, it accounts 3 to 5% of emergency and OPD visits. There's a high rate of misdiagnosis and unnecessary imaging. Posterior circulation strokes commonly missed. And the correct bedside diagnosis will lead to a rapid relief and which will be a cost-effective care. Today's my objectives are apply a structured clinical approach, distinguish peripheral versus central vertigo, identify dangerous red flags, avoid common diagnostic and management pitfalls. What exactly is vertigo? Vertigo is the illusion of movement, usually spinning. The patients may come to you as කරකැවිල්ල, as කළු වෙනවා, වටේට කරකැවෙනවා, වැටෙන්න යනවා. So many presentations will come. You have to differentiate from pre-syncope disequilibrium. Calling all dizziness and labeling it as vertigo is the pitfall. The key clinical question we have to differentiate is whether is this peripheral or central in origin. It will determine the urgency, need for imaging, admission and the prognosis. So I would like to give an illustration how to differentiate peripheral versus central vertigo. Normally the peripheral vertigo is sudden onset. But central vertigo, usually, it might be sudden or gradual. In severity-wise, the peripheral vertigo is very severe. But central vertigo, most of the cases are mild to moderate. And there is nystagmus, which is unidirectional in peripheral vertigo, whereas in central vertigo, the nystagmus is vertical. The most important sign, the neurological signs are present in central vertigo and absent in peripheral vertigo. The hearing symptoms are more common in peripheral vertigo and rare in central vertigo. In history taking, the clinical pearl, we have to ask in deep the duration. We have to go in deep to ask whether it's seconds, minutes, hours, days, likewise. Then what are the triggering factors? It might be the position change, head movement, some kind of food, and the associated symptoms. Whether the hearing loss is there, headache, any weakness, and the vascular risk factors. Timing and triggering factors are more important as symptom quality. The real game changer in spinning patient is the bedside examination. We have to observe for the nystagmus, then the head impulse test, test of screw, Dix-Hall-Pike test, and the gait assessment. A good bedside examination often beats early MRI. We don't need to rush to do imaging. We have to do a proper examination and we have to take a proper good history when we are examining spinning patients. In HINS examination, that is head impulse, nystagmus, test of screw. The central signs, normal head impulse test, direction, there is changing nystagmus and screw deviation. That is more sensitive than early MRI for stroke. We will move on to the case presentations now. My first case is a 58-year-old female who presented with complaints of recurrent episodes of spinning sensation for 5 days. She described the vertigo as sudden in onset. Each episode lasts less than 30 seconds, triggered by turning in bed to the right side and looking upward, associated with mild nausea. There is no vomiting. There was no hearing loss, no tinnitus, no ear fullness, no headache, no focal neurological symptoms like diplopia, limb weakness. She reported difficulty sleeping due to fear of triggering the spinning sensation. On examination, the vitals are stable. Otological examination is normal. Then the neurological examination also normal. DHP, that is the Dix-Hall-Pike maneuver, which we can do in our GP setup. If we have a couch, we have to ask the patient to sit on the couch little behind, like further behind, and turn the head 45 degrees to one side, and we have to ask the patient to lie down hanging the head edge of the bed. Then we have to observe for the nystagmus. In this case, the DHP is positive to right side but negative to left side. What could be the diagnosis? There are so many differential diagnoses. But in this case, the key features, the typical features are positional trigger. That is, with head movement, the patient develops vertigo. Then the duration, which is very short. It is less than 1 minute. There is no auditory symptoms and DHP is positive to right side. So, my first case presentation diagnosis will be right posterior canal BPPV, which is the most commonest type of the vertigo. Then we will see the pathophysiology of BPPV. It is the displacement of otoconia from utricle. You can see in the diagram, like very illustrately given, the canalithiasis in posterior semicircular canal, abnormal endolymph movement during head position change, transient stimulation of the ampulla, which triggers and develops the vertigo. Then the management. The Epley-Canalith repositioning maneuver is performed, which will lead to an immediate reduction in symptoms. Normally for BPV, only doing Epley, we can manage a vertigo patient. Then we have to advise the patient to avoid sudden head movements. එක පාරටම පිටිපස්ස බලන්න එපා. උඩ යට බලන්න එපා. ඔළුව පිටිපස්ස බලනවා නම් මුළු ඇඟෙන්ම හැරිලා බලන්න. Those things we have to give proper instructions to the patient. Then if you follow up the patient in 1 week's time, most of the patients will come in complete resolution of symptoms without any treatment, just by doing the Epley maneuver and giving good advice. So as GPs in our practice, we should learn how to convince the patient, how to reassure the patient, and sometimes if you want, you can prescribe some beta histidine along with this maneuver for further management. Let's move to the case 2. He is a 42-year-old male presented with sudden onset, severe spinning sensation for 24 hours. Here, the sensation is for 24 hours. Then he describes the vertigo as acute onset rotatory vertigo. වටේට කරකැවෙනවා. Continuous and severe. Aggravated by head movement. Associated with nausea, multiple episodes of vomiting, and imbalance while walking. Also, he reported a recent upper respiratory tract infection 1 week prior. Like the previous case, in this case also, there is no hearing loss, no tinnitus, no ear fullness, no diplopia, no dysarthria, no limb weakness, no sensory symptoms. Then on examination, general examination, the patient's vitals are stable. Patient lying still, avoiding head movement. Then the neurological wise is normal. Eye examination, there is unilateral nystagmus. Head impulse test is positive. Then the cerebral signs is negative. No limb ataxia, but there might be gait unsteady but able to stand with support. This is also a bedside diagnosis. Just by the history, we can come to a diagnosis. There is continuous vertigo, which works with head movement. But here, there is recent history of upper respiratory tract infection. That's the difference from the BPV. And there is no hearing loss, no tinnitus, no focal neurological deficits. So, the case 2 diagnosis is vestibular neuritis. In vestibular neuritis, in the management wise, for the vomiting, we can give antiemetics, then there can be short-term vestibular suppressants. If needed, we can give IV fluids, and we have to early mobilize the patient, and steroids, prednisolone within 72 hours may improve vestibular recovery, but still it's debated. Then vestibular rehabilitation can be done. Now we will move on to my case 3. A 46-year-old teacher presents with recurrent episodes of spinning sensation for the past 8 months. She describes true rotational vertigo lasting about 2 to 3 hours per episode. She also reports left-sided ear fullness, tinnitus, fluctuating hearing difficulty. She has no diplopia, no dysarthria, no lip weakness or ataxia. On examination of this patient, during the attack there might be horizontal nystagmus. But in between attacks, if you examine, the patient might be otoscopically normal and no neurological deficits. Here we can do a pure tone audiometry to see the hearing. There is low frequency sensory neural hearing loss. In the figure here, you will see how the unilateral low frequency hearing loss is appeared in a PTA. So the key features of the third case are more than 2 spontaneous vertigo episodes which last 20 minutes to 12 hours, audiometrically documented sensory neural hearing loss. If you don't have the machine for PTA facilities, you can do Rinne's test, Weber's test and see whether it is sensory neural hearing loss. Then the fluctuating oral symptoms are there. So the third case diagnosis will be the Meniere's disease. In Meniere's disease, the management is we have to restrict the salt. We have to ask the patient to have a low salt diet. Then diuretics may help, beta-histine and the intratympanic steroids are indicated here. The case 4 will be a 42-year-old banker who presented with a sudden onset spinning sensation for 2 days associated with reduced hearing in right ear. He described acute onset severe rotatory vertigo which is continuous, worsens with head movement associated with nausea and vomiting. There is right-sided hearing loss, tinnitus present. There is no ear discharge, no focal neurological symptoms. There is history of upper respiratory tract infection 1 week prior. In this case, if you see, like in the previous case, there is upper respiratory tract infection. There is hearing loss. On examination wise, the vitals are stable, febrile, otoscopically normal. Then the spontaneous horizontal nystagmus is present. There is positive head impulse test to right side. Romberg's falls to right side. Neurological examination is normal. And here, like I have given the bedside hearing test, as we are GPs, we can't go for an audiometry. If you do Rinne's test, here the positive bilaterally and Weber's will be lateralized to left ear, which will suggest this is a right-sided sensory neural hearing loss. In this case, the differential diagnosis, we will now compare as we have done like 2 to 3 cases now. If it is labyrinthitis, there is continuous vertigo, and vestibular neuritis also have continuous vertigo. Posterior circulation stroke also will get continuous vertigo. Out of 3, the hearing loss is present only in labyrinthitis. Then if you get Meniere's, the vertigo is episodic and there are also hearing loss. And duration wise, labyrinthitis and vestibular neuritis, the patient will tell about in days. But in Meniere's, it might be minutes to hours. In posterior circulation stroke, it is variable. So in this case, we have to do some investigations. PTA or bedside hearing assessment, MRI brain, if red flags are present, then the blood test if infective cause is suspected. The diagnosis of this case presentation will be acute viral labyrinthitis. Most likely it is post-viral. In labyrinthitis, the pathophysiology. There is inflammation of vestibular apparatus which will lead to vertigo part. Then there is cochlear inflammation which will cause the hearing loss. So the common causes in most of the common cases are viral. Bacterial is rare, but if it is there, it might be from otitis media. In labyrinthitis, in acute phase management, we have to give vestibular suppressants for a short term. Then antiemetics, oral steroids, and good hydration is needed. If bacterial is suspected, IV antibiotics might indicated. Then we have to do an ENT referral urgently. During the recovery phase, early vestibular rehabilitation, and we have to avoid prolonged vestibular suppressants. We will move on to the case 5 now. The 38-year-old female who is an accountant presented with a history of recurrent episodes of vertigo for 1 year. Episodic spinning sensation lasting 30 minutes to 6 hours and sometimes up to 24 hours. Associated with photophobia, phonophobia, occipital throbbing headache and motion intolerance. There is no persistent hearing loss. Some episodes are triggered by sleep deprivation, stress, food like cashew nuts, chocolates and caffeine. In the past and family history, she gives a history of migraine for 15 years. Mother also has migraine. There is no vascular risk factors. On examination, there is spontaneous or positional nystagmus. There is no focal neurological signs and otoscopic examination is normal. If you take this case, there is more than 5 episodes of vestibular symptoms, which is 5 minutes to 72 hours. There is current or past history of migraine. More than 50% episodes associated with headache with migrainous features, photophobia, phonophobia and visual aura. So the case 5 presentation will describe a scenario of a vestibular migraine. In vestibular migraine, the management of an acute attack will be NSAIDs, triptans, antiemetics. For the preventive therapy, we have to give beta blockers like propranolol, flunarizine, amitriptyline and topiramate. Then we have to advise on lifestyle measures, sleep hygiene and trigger avoidance. My last case presentation will be a 45-year-old female typist presented with recurrent dizziness for 3 months. She reports intermittent episodes of non-rotatory dizziness, sensation of unsteadiness rather than through spinning, which is triggered by neck movements. There is prolonged computer work, sudden head turning. Duration might be minutes to hours. Sensation of unsteadiness rather than true spinning. The associated symptoms are there is neck stiffness, occipital headache. In this case, there is no tinnitus, no hearing loss, no ear fullness, no diplopia and no limb weakness. In the past medical history, there is no diabetic or hypertension, no previous stroke. History of cervical spondylosis is present. On examination, general examination, vitals are stable. On neurological examination, no focal neurological deficits. The cranial nerves are normal and the cerebral signs are absent. Then the ENT examination, the otoscopy is normal, no spontaneous nystagmus. Cervical spine examination, there is reduced range of motion, paraspinal muscle tenderness, reproduction of dizziness with neck rotation. Then the vestibular assessment, Dixwell Pike test is negative, head impulse test is normal, Romberg mild unsteadiness is present. Investigations, in a case like this, we can ask to do a cervical spine X-ray lateral view. It will show the degenerative changes. Then the MRI brain will be normal. Then if you do audiometry or bedside hearing assessment, which will be normal. What could be the diagnosis? This is a case of cervicogenic vertigo. Here the key features are neck pain, dizziness linked to neck movement, reproduction of symptoms with neck movement. The exclusion is based on negative vestibular workup. In the management of cervicogenic vertigo, first we have to do conservative management, that is cervical physiotherapy, postural correction, isometric neck exercises, and SSIs short term may be given. Then adjunct with that, we can give vestibular rehabilitation therapy. To keep the neck movement still, we can ask for a soft cervical collar. Now we'll see how to differentiate the common clinical scenarios. In BPVV, there is no hearing loss. The duration is here, it's in seconds. The key feature will be positional triggers. In vestibular neuritis, also there is no hearing loss, but the duration will vary up to days. And most of the cases here it's post-viral. The other case which will present to you with post-viral infection is labyrinthitis. Here, to differentiate vestibular neuritis with labyrinthitis, the key feature will be the hearing assessment. There is hearing loss in labyrinthitis, but no hearing loss in vestibular neuritis. The duration, both of the cases are almost equals in days, and there is sensory neural hearing loss in labyrinthitis. In many years, the hearing loss is present, which is also sensory neural hearing loss, but the duration will be hours. But in labyrinthitis, the duration is usually in days. In vestibular migraine, there is no hearing loss. The duration might be minutes to hours, and there is typical migraine features. And posterior circulation stroke, the duration is variable. There might be hearing loss or there might not be hearing loss, and the key feature will be neurological deficit. It is important to consider continuous vertigo, vomiting, gait instability. Labeling as vestibular neuritis, we have to perform hints. Then we have to rule out stroke, which is a red flag sign. The red flags not to be missed in a vertigo cases are new neurological deficits, severe ataxia, vertical nystagmus, sudden severe headache, and vascular risk factors. If these symptoms are present, we have to do urgent neuroimaging and referral. The common pitfalls which are in practice are overuse of CT brain. Like as you see in the previous 6 cases, Out of 6 cases, only about 1 to 2 cases might need CT brain for come to a proper diagnosis. Some cases we can diagnose in the bedside, and we don't need to miss posterior circulation strokes. Then overprescription of vestibular suppressants. The vestibular suppressants we can prescribe for a very short period and we can tail off gradually. Then failure to perform positional testing. By just looking the eye movement, we can rule out some cases. Labeling everything as labyrinthitis, also a common pitfall in practice. Then we have to think in mind the red flags. We should never ignore the red flags. It is alarming. Not to be missed a posterior circulation stroke. Imaging. When is it really needed? The indications of imaging are if there is focal neurology, central signs on examination, new severe headache, and high stroke risk. Imaging wise, MRI is better than CT for posterior fossa. Then the treatment pearls. For BPPV, repositioning maneuver, then that's a Epley maneuver will cure the vertigo. In vestibular neuritis, early steroids and rehabilitation. In Meniere's disease, salt restriction, beta histine and diuretics. In labyrinthitis, IV antibiotics may needed. In vestibular migraine, we have to give migraine prophylaxis. The take-home messages are not all vertigos is the same. If episodic seconds, we have to think about BPPV. Episodic hours, hearing loss, we have to think about Meniere's disease. If it is minutes to hours and migraine features, think vestibular migraine. If it is continuous for more than 24 hours, we have to think about acute vestibular syndrome. So the duration is your first diagnostic tool. Then the ear speaks, so we have to listen carefully. Fluctuating hearing loss is never BPPV. Normal hearing pushes you towards migraine or neuritis. Progressive hearing loss demands imaging. In continuous vertigo, we have to rule out stroke first. We have to perform hints properly. A normal head impulse test in continuous vertigo is stroke until proven otherwise. Most diagnoses are clinical. Vertigo is rarely confusing. It becomes confusing only when we don't listen long enough to the history or look carefully at the eyes. Now the forum is open for questions.
If anyone has any questions, please feel free to just unmute and ask, or you can type it in the chat box. I think we have one question, Dr. Nirukshi, in the chat box. They are asking whether you can show us some neck physiotherapy exercises. I'm not sure if that's possible, but...
Like neck physiotherapy, like most of the cases, we are giving heat therapy. Like in our department, like we are asking for a heat therapy. Like we are not, like we don't know if it is cervicogenic vertigo, like severe physiotherapy may be harmful. So we will be starting with heat therapy and going forward.
Any other questions? One more question that has come, Dr. Nirukshi. Is it okay to prescribe Stemetil in BPPV?
Yes, you can use the drugs which we are normally prescribing are beta histidine. Like if it is very severe case, we can start from 24 milligram TDS, then we can gradually reduce to 16 milligram TDS, and further we can tail off to 8 milligram TDS likewise. And Stemetil is an option, but we should not give Stemetil for a long time. Especially in pregnancy, we can use Stemetil. And other than that, like in most of the vertigo cases, we are giving cinnarizine, flunarizine, those kind of drugs.
There's another question in the chat box of Nirukshi. Can you please explain more about heat therapy? How do you do it?
Wait. Normally, I don't have a slide in for heat therapy in vertigo. Most of the time we are using hot or cold therapy. In the clinical setup, mostly we are using hot therapy. For that also we are referring to the physiotherapy department for heat therapy. If you apply correctly, the heat therapy offers several benefits for vertigo related symptoms. It will relaxes the tense neck muscles, and it will be a primary way the heat helps by elevating the cervicogenic dizziness mainly. For BPP, you don't need to give heat therapy. Only for the cervicogenic vertigo, we have to have heat therapy.
There's another question, Nirukshi. Is syncope an emergency?
Syncope might be emergency, but because we can't miss out a posterior circulation stroke, which might come as a syncope. So we have to do proper imaging and do the necessary other investigations and rule out. And if it is negative, then we can think this is a dizziness, vertigo, spinning sensation, and go ahead with the treatment.
Another question, what are the indications for urgent MRI for a patient who comes with vertigo?
The urgent MRI, as I told before, the red signs will be that alarming signs. If it is, wait, I'll show the slide to you. MRI is mainly indicated in posterior circulation stroke, for a dizziness patient for BPV, vestibular neuritis or labyrinthitis, Meniere's or migraine, we don't need to do MRI. If the hearing loss might or might not be present in posterior circulation, the duration will be variable in posterior circulation stroke. If the key feature is neurological deficit, if there is diplopia, ataxia, limb weakness, then it's a posterior circulation stroke. Then the MRI is indicated.
Okay, there's another question. Can children get vertigo?
Yes, some children might get vertigo, especially during the exam time, they are focusing mainly on studies, there is sleep deprivation, migrainous attacks might come, due to vigorous head movements during sport activities, uh, there might be displacement of the otoconia, then there might be vertigo, but not severe.
Okay, are there any more questions? You can type it in the chat box in the next couple of minutes. Are there any more questions?
Like as somebody has asked about heat therapy, like heat therapy for vertigo, like as I told before, it's mainly for the cervicogenic dizziness, which is caused by neck tightness and muscle involvement. So to applying warm moist heat to the neck and shoulders for about 15 to 30 minutes, which will resolve the cervicogenic vertigo. But for the other cases, the heat therapy will be not effective. And we can give muscle relaxants like alprazolam, prescribe those kind of drugs along with the cervical collar, and there might be some like ketoprofen gel or some diclofenac gel or some gel to apply because of the neck pain. The dizziness is coming in cervicogenic vertigo.
There's a few more questions, Nirukshi. One is, in dental pathology, can you develop vertigo?
Yes, like due to displacement of that like small particles in the sacules and the utricles, if it dislodge, you can develop vertigo. It might be very mild to severe in nature. So that's why if it is mild, you have to go for a proper ENT team and get the advice. Sometimes you might not need any treatment. Just by doing a DHP, Dixolpike maneuver, we can assess the patient, and doing the Epley maneuver by repositioning the things, it will be corrected. Like it's magical, no need of any treatment. So like we should not miss any case of spinning. Like in our GP setup also, if we have a low lying couch, we can do it in our GP practice.
There's also a question about what's the treatment for pediatric patients with vertigo?
Normally we can start with a low dose of beta histidine. Like according to the body weight, we can give like 8 milligram or 4 milligram BD or TDS, we can prescribe without any harm.
Another question, Nirukshi, what's more effective, beta-circ or stemetil for BPPV, and how long to continue it for?
Normally, like for BPV, either beta-circ or stemetil is not necessary. As I told before, like only doing the Dixolpike, we have to correctly identify which side is positive. Then if we correctly do the Epley maneuver, it might not like resolve in one Epley maneuver procedure. We might need to repeat it again and again. Like by doing that also it will improve. Like on other side, we can start a small dose of beta histidine or stemetil. But in stemetil, normally we are not giving for a very long time. Like stemetil 5 milligram TDS or BD for 1 week time. Then you can tail off. In beta histidine in a very severe vertigo patient, you can start even 32, we can start, or 24, then 16, 8, we can gradually tail off. Both are equally working, like, but in ENT hospital-wise setups nowadays we are mostly prescribing beta histidine than stemetil.
Okay, there's another question. Can we prescribe stemetil, cinnarizine, and beta-histine all together?
If it is very severe, yes, we can prescribe. Even cinnarizine 25 milligram BT we can prescribe. We can along with that we can add gravinate also. Gravinate 50 BD or 25 BD also we can add. Like we can start with the all combination, but we have to tail it off quickly. Don't keep the patient on for a very long time, not a lifelong drug. Like on and off, if it is vertigo is there, we can ask the patient to take.
Another question, what's the treatment? Sorry, Dr. Nirukshi, continue.
But for the Meniere's disease, I have to tell, like you can't have a short duration, short course treatment for the Meniere's disease. If you like in treatment of Meniere's disease, it will be long-term treatment and we have to gradually tail off, and if it is symptoms recurring, then we have to again rise up the treatment manual.
Another question, what is the treatment for pregnant women who have vertigo other than Stemetil?
Most of the cases, like if it is BPV, it's very hard to do Eplemanua or DHP. So like with the slight dose of Stemetil, usually it recurs. Like if it's very, very severe, we can prescribe beta histidine under the guidance of the obstetrician.
Okay. In recurrent vertigo, how do we decide between diagnosing BPPV and early Meniere's disease, especially when audiometric findings are subtle?
In BPV, there is no hearing loss. In Meniere's, there is hearing loss. And in BPV, it is duration wise, it's only seconds. And Meniere's, it is long duration. He will tell about hours. So it's easy to diagnose. No need to have a pure tone audiometry for the diagnosis. By simple bedside examination, we can come to a diagnosis. We can differentiate BPPV and Meniere's disease.
There's another question, Nirukshi. Will amitriptyline be helpful in BPPV?
Sometimes it's helpful.
Another question, is there treatment for tinnitus?
Tinnitus, like to increase the vascularity, we can start flunarizine or cinnarizine. Like if there is prolonged tinnitus, we have to do a PTA, then tympanogram, and if it's further developing without resolving, we have to go for imaging, and other blood investigations might also be indicated if there is a prolonged tinnitus which is not correcting. And sometimes dexamethasone will work out for the tinnitus, or prednisolone.
Any other questions? You can type it in the chat box or unmute yourself. I think that's all the questions. So we can now actually wrap up today's GP Cafe. A big thank you, Dr. Nirukshi, for a very insightful, practical, and concise discussion today. And a big thank you to all of you for joining as well on today's discussion on vertigo. I hope the session has provided clarity and practical insights that you can take forward in your GP practice. So thank you again, and good night.
Thank you. Good night.